Don't worry, you don't have questions.
Okay.
Don't worry, we can handle that.
Okay, so Professor, I think we can start. I will pass to you the hosting, and I will come back later.
Sorry, just a moment.
Ah, it's okay.
Okay.
Yeah. So we can start.
So dear friends and colleagues, welcome to the 5th CSRS webinar. Today I have as a co-chairman our distinguished president from CSRS Europe.
Hi everybody.
Hi. You know, for several reasons, most of the topics in spine congresses deal with very complex techniques and technologies that actually don't apply to 3/4 of the world population. So we at CSRS, we took this very at heart, the topic of practice of spine surgery in low and middle income countries, and we elected today as the main topic for the webinar. You know, there is a variable distribution worldwide of expertise, training, and technologies, and this creates local idiosyncrasies that are associated with very different clinical practices and standards. However, nobody is totally right, nobody is totally wrong. So the relevant commitment from our side is to improve patient outcomes with the local available human and financial resources, instead of arrogantly label local practices as suboptimal. So I hope this webinar, where we have people from Africa, from Brazil, from Pakistan, we'll find some solutions and we'll create bridges to fill the gap of practices. So without further delay, I would like to introduce our first speaker. Professor Ahmed Amar is Professor of Neurosurgery at Daman University in Saudi Arabia. He's a prolific book writer, and I would advise his book on ethics in neurosurgical practice, published by Springer. He's a member of WFNS Ethics Committee and Neurosurgical Training Standards Committee. And he will deliver what I think it's a very important lecture on an ethical perspective about the challenges of healthcare is facing in low and middle income countries. Ahmed, please.
Thank you very much, Oscar, for the invitation. And I am very glad to join this distinguished group to discuss really, that is how the neurosurgery is developing in the world. I would like to, first, I have nothing to disclose. If we would like to, before starting, to see where we are now, we are actually in the edge of market development in the technology and in the education and in medical practice and in every aspect of life, and especially also in medical practice. But there are questions about the human rights and what about the patient rights. We talk a lot about patient rights, but we will discuss it later from this perspective. And doctor-patient relationship, how it's coming to be formed in the time of robots and IT. And what is most important, I highlight here about justice in medicine. So if we look at an overview of the global healthcare system today, first of all, we have to emphasize on a fact that is the very first statement in UN Human Rights Declaration is that every human being has the right for house, food, water, and access to medical treatment. So the right for be treated effectively is a fundamental human right. And this has to be emphasized all the time. But there are conflicts in the low and middle income countries about resources, about facilities, about manpowers, about the communication, about IT and extra. But even in the major industrial countries, they have another source of problem. As we will see, in the third of the people in the United States, they have no access to advanced medical treatment because of the health insurance, and also about the waiting list and the facilities. So the ethical question came: how would you like to be treated? You treated as you deserve to be treated, or as you want to be treated? If we look for the group, I just quote from study, great study done by, published in Journal of Neurosurgery and done and performed by the Global Neurosurgery Group. They found nowadays there are 5 billion people don't have access to a safe, affordable surgical anesthetic care when needed. In low and middle income countries, 9 out of 10 have no access to basic life-saving disability advancing surgical care. There are 143 million additional surgical procedures are needed every year, but cannot be done. So if we look at this, which is frightening, the people who dies because of lack of facilities or access to medical treatment, 3/4 of the people dies of infection or other problem. And this is really frightening issue. But also you can see the shortage of, that is in the around 13.4 million new cases arise every year. Out of this, 60% of these cases, traumatic head injury, with spinal injury, with stroke, with tumor, and hydrocephalus. We can find that is the manpower. Find, for example, China and Japan, they have 18,000 neurosurgeons. Europe, 10,700. United States and Canada, over 5,000. India is over 3,500, but all Africa, only 488 neurosurgeons. Is there a chance, is there a light in the end of the tunnel? Yes. If there is, we can invest more in health care systems in the low and the middle class countries. What are the challenges facing developed countries? First, the gap between industrial countries and developed countries are widening day by day. The number of people under the poverty lines are increasing, especially this year with the COVID-19. But worse than this, the scholarship for doctors from developed country to be trained probably in advanced country are reduced. And the hospital in the developed countries are located mainly in the major cities, and the rural area have no major hospital and no advanced treatment. And also there is lack of efficient transportation system. These are really challenging what they are facing. And there are also rapid development in the technology and the medical technology, drugs, equipment. But all this high tech are very expensive and cannot be, affordable in low income countries. There are advanced, and this is good, there are many countries, they have their own local training program. But still the local training program are starving and need supported. Here comes the ethical problems. If we look how every individual neurosurgery in low and middle income country facing these troubles. And we have to look at it from the concept of metacognition. Metacognition means thinking of thinking, or awareness of self-awareness. So how can we think about what we have? So they are aware about almost all the neurosurgeons or in the low and middle income countries, they are aware about the state of art and of managing the cases. But they don't have the resources. They don't have the equipment. They don't have enough hospital bed. They have lack of manpower and doctors to cover all the facilities. And plus this, their personal income is lower in governmental hospital. So they have to go for private business in order to have a good life. And this is make already the shortened number of doctors be more shortened. And they have, but every one of them, they have dreams and commitment to provide best possible care for their patient. And another problem which we face that is they cannot publish easily problem with which is needed for career development because they don't have the equipment that is to publish the good papers in good journal. Something which comes out, and I heard about it and discussed in several meetings, about should they feel guilty if the evidence of the evidence-based medicine guideline, the other guideline cannot be implemented and followed? And my answer is no, because it's still evidence-based medicine. It's a guideline and has a lot of problems we may discuss later. So what are the individual doctors going to deal with this? We can see two groups. Group get the best by the situation and they only dream to migrate to Europe or the West or wherever rich countries, and for time being just to do what is necessary, but they live in a dream to immigrate. Another group, which is really, I can see a lot of them now, they are creative. They are thinking out of the box. They design their own small instrument and they try to find solution for the problem they do have. But the problem is, there's no big companies likes to manufacture their products. I saw beautiful shunts made. I saw beautiful screws made. I saw beautiful drains made by very low cost, but it's only local. And the problem is, whatever, always the ethical problem, autonomy, patient right. And our commitment as do no harm for the patient, even we use this out-of-box ideas. And always try to do good for the patient, and that could be the motivation to do something. But about justice, we see the father of philosophy and one of the father of ethics, Aristotle. He said, and I think we have to think about it twice and three times, always, we are required to treat similar cases alike. Do we do that? I am not going to go in detail about evidence-based medicine, but there are problems about how evidence is the evidence and how ethical is each evidence and how the data is collected. But this is, at least it is a good standard, but it is not something you should follow blindly. And if you don't follow because you don't have resources, you shouldn't feel guilty. So then we came up with another concept, what we call values-based medicine. Yes, medicine since it started goes hand by hand with the advancement in technology and knowledge and science. But medicine also, since it's a very, very starting age, it's based on values and based on ethics. And the principle or concept of value-based medicine is concept to ensure observation and the implementation of ethical principles in every step of medical care and research. So what's ethics? Is it what we believe or what we practice? Is it what we understand or what we interpret? Is it what we behave or what we think about? Or is it an individual ethics or a group ethics? In fact, it is all of that. And what is value? Value is value when its value is valued. It means the value is only value when you value that thing. So when we are in certain circumstances, we should value what we are doing and we should do the best for what we have. So the pillar of principles of medical ethics, autonomy, which includes patient right to refuse or accept and know about everything. Non-beneficence, it means do no harm. Beneficency, it means do the good for the patient, and justice and dignity and trustfulness. From the beginning of Hippocrates and the early ethics, medical ethics, when it started, there are two principles. That is non-beneficence, do no harm, and do good for the patient. But what about justice? What about the patient has the human right declaration, the patient has access to proper health facilities? It's impossible to ask about equality of all the patients, all the world, to have equality in having the same machine, same gamma knife, same very advanced technique. But at least we should have equity. The patient should enjoy the scene. They should at least have minimum access to a good life care, good health care to save their life and treat their disease. They have the right to do that. So what we are talking about justice and is the acuity now for justice in medicine. So ethical roadmap the ethics may help us to find a solution in this dilemma. If we learn something from COVID-19 lessons, that's regardless how rich the country or poor, all we get affected by the COVID-19. All we get in disaster by COVID-19. So if we shared the very bad and hard time about the COVID-19, can we share a good time and the prosperity if we work together to advance the healthcare system and the education in all the world? I think this is a lesson we have to learn and we have to advance. So in order to do this, we have to advance the training of the people. Could be in job training. It doesn't need a trainee to travel all the ways. With the new technology, telemedicine and others, could be good job training, on-job training, but needs a special training program to be designed. And also the donation with goodwill is very, very welcome. Thank you very much. I hope I did not exceed my time.
No, Hamed, thank you for this very insightful lecture. As you said, ethics can help us and guide us to fill these gaps. I'm just trying to launch the inquiry about your. So can you read them, Hamed, please?
Yes, I read them. So the first question is, what is the most neurosurgical problem causing death in low and middle income country? Is it the spinal disorder or head trauma, infection, or brain tumors?
Okay, you just go ahead. Can you?
The second one, I will tell the answer or no. The second one, how many neurosurgeons should be trained to meet current needs? 10,000, 15,000, 20,000, or we need more than 20,000?
Okay, so I think better to answer. I don't know why there is a technical problem here.
The first question, of course, it is head trauma.
Right.
The head trauma now it is more than infection in the last WHO in first country. Second, yes, we need more than 20,000 neurosurgeons are badly needed in low and middle income countries.
No, question 3. The 3 key components.
Sorry. Okay, I didn't come to it. Where is I cannot see it.
And number 3, the 3 key components of evidence-based medicine are all accepted.
The key component of evidence-based medicine are all except research-based, outcome of medical and surgical cases, clinician accumulated experience, patient value, and preference. All are key component of evidence-based medicine, but B, the outcome of medical and surgical cases.
Question 4.
Question 4, the concept of justice in ethics is that all health resources must be distributed according to the principle of equity, taken as number B, taken as patient right to choose or refuse treatment, or for medical professionals to do good for all patients under circumstances, or do obligation to do no harm for the patient. All are different principles, all what is of ethics. But what is we emphasize now in this circumstances is A, justice now that it should be distributed equity, not equality.
So these are the results. Thank you. So actually, people think head trauma is the most significant problem. As you said, more than 20,000 neurosurgeons. for question number 3, people split between B, C, and D. And the concept of justice in ethics is people think the most important is number A.
Good. That's correct. Good.
Okay, very good. Aiko, do you want to make some comments?
Yeah, appreciate, Professor Amara, your lecture, and you gave a very good point regarding out-of-the-box thinking. So I only can motivate every participant who have the same struggling with limitations, that you have to reach out to local industry regarding the standard implants. So standard implants these days can be made in any country everywhere, because the industry setting usually is there, and we don't need rocking science. And there are a lot of patent openings, so you don't evaluate patents if you go for standard screw rod systems or plates or so. So I can only motivate everybody, reach out to local industry and to politics to get these standard implants, which are very important for trauma care, as you said, and as you stressed, and usually it works. And if there's any question for this, people can be open to contact me. Yeah. If there are any colleagues, any requests for this, and I can help them, so please reach out. It can be done.
Excellent.
Thank you. This is
nice
great.
lecture. Nice lecture. Very
Thank
good.
you very much.
So next we have Ignatius Essene. He's a rising star in African neurosurgery. He's chief neurosurgeon at the Garoua Hospital in Cameroon. He has a master on public health. He's a chairman of Young African Neurosurgeons Forum and co-chair also of the FNS Young Neurosurgeons Forum. And is bringing a critical appraisal on evidence-based guidelines that have origin in first world countries. Are they applicable or not in low and middle income countries? Please, Ignatius.
Thank you so much, Professor Oscar, for giving me the opportunity to be here with you this evening. Well, I'm going to be talking about the applicability of evidence-based medicine guidelines in LMICs. Well, I'm from Cameroon, and Cameroon is a country which everybody knows famous for football. And I work in the northern part of Cameroon, covering a population of about 10 million as a single neurosurgeon. And I teach in the university in the northwest part of the country as a pioneer neurosurgeon in that university. So this afternoon, we're going to look at the applicability of guidelines in LMICs. I'm going to briefly give you an overview of the concepts of evidence-based neurosurgery, the critical appraisal tools, and how to apply, how this can be, evidence-based medicine can be applied in LMICs. So these are going to be based on some of the most recent publications, some of which I did with Professor Ahmed Amara, who supported me very much during my training in neurosurgery in Cairo. And we actually published 2 papers together on the concept of evidence-based neurosurgery, even though he is now tilted towards value-based neurosurgery. Evidence-based neurosurgery is, came up in the 90s, and Professor Saget defined it as the consensuous, explicit, judicious use of current-based evidence in making decisions about patient care, individual patient care. And as Professor Ahmed said, it is a paradigm shift, and it has a number of building blocks. The first of which is the best research evidence, surgical expertise, experience, and the judgment, patients' values, preferences, and expectations to provide optimal care to the patient. The evidence can be obtained from studies that can range from descriptive through analytic to integrative studies. They are usually ranked into level of evidence. And when after evaluation for the quality using the guidelines, which we are going to see very shortly, they are then graded into strength of recommendation and hence guidelines. But this is just an overview of the common study designs we find in neurosurgery, from descriptive studies on the left through analytic studies and secondary designs like the meta-analysis, which fall under integrative studies. We're not going to go into details about this. So when we have these studies, there are 2 ways to look at it. There's a 5-tier classification, which looks at the studies from level 1 to level 5, with RCTs being at the top of the pyramid and case report and expert opinion at the base of the pyramid. But this can be has been rearranged into the 3-tier classification, which is much more applicable when it comes to talking about grading of recommendation. So we have class 1 evidence, which is the RCT, the randomized surgical trial. Then we have the observational studies, the cohort and the case control study, which are put under class 2 evidence, and then have the rest put under the class 3 evidence. So when these studies are assessed for quality, how do we assess for quality? There are a number of tools that we have been developed over the years. We have the Oxford tools, we have And we have the great tools which are used to assess quality. But the commonest use in the literature at the moment, we have the Equator guidelines enhancing the quality and transparency of health research. For example, we have these tools, checklists, they help us to look at the methodology and the reporting of these studies for us to be able to know if a study is of good quality or not before applying it, the research evidence to patient care. So we look for the relevance, the validity, and enables us to be able to grade the evidence. For example, this is one of the papers which we published recently, looking at how we can adequately interpret a meta-analysis, because in addition to the PRISMA guidelines, which I just showed before, we need to look deeply into other aspects, not only just the methodology and the reporting. We need to go deeper into that. So when you have looked at the studies and assess their quality, they are then graded into recommendations, sometimes called practice parameters, practice guidelines, or consensus statements. We have 3 levels. We have level 1 recommendations, which we always say is high degree of certainty, level 2, moderate degree of certainty, and then level 3, which is low degree of certainty. But in spine surgery, as we're talking about spine, which is the commonest is the A, B, C, D classification, which is used by the NAS in North America. So having understood the concept of how we came about to having classified the evidence, we said evidence-based medicine has a number of building blocks. We have the best research evidence, but aside the best research evidence, we have surgical expertise, experience, and judgment, because the surgeon has a role in applying the best research evidence to the patient. So if a surgeon has an expertise in, say, the endoscope more than the microscope, even if the best research evidence says we have to use the endoscope, he will use the microscope because he doesn't have enough expertise in the endoscope. Another aspect which my previous speaker brought up was the patient values, expectations, and preferences. You won't force a patient to give him or her a treatment. The patient has to agree before the treatment is being delivered. And then there's one concept which I raised in my paper in 2020, which people always forget, is the context, the setting, the clinical circumstances. The standard of care has to be adapted to the local realities, okay? So, but how do we come about with the concept of evidence-based medicine? When there's a problem, well, a patient has a problem, we can translate this into using the classical PICOS format, get data, analyze it for the validity and usefulness, and then summarize and formulate recommendations before applying it to the patient at the micro level or to the population at the macro level. So briefly, this is how this is the methodology of the evidence-based approach to applying evidence to patient care. So let me give an example to illustrate how, or the applicability of guidelines in low and LMICs. For example, there's a common question, which is that of using the magnifying loupes and the microscope for microdiscectomy and microdecompression. This was a study published in 2012. It is a retrospective study, well, very low in level. You can put it level 4. And the conclusion was that microscopes are better than the loupes in terms of visualization, patient, the comfort of the surgeon, and the teaching tool. In a recent study which we published a few years ago, which I was privileged to help the designing and doing the statistical analysis, we compared the loupe and the microscope, and it was a prospective cohort study. And we concluded that, there was only one difference, which was statistically significant, the muzzle separation. The rest of the parameters were not different between the microscope and the loupe. So, but if you look around the world, the standard of care is the microscope in doing discectomy. In most LMICs, the microscope might not be available. So when a patient comes, is it unethical to use the loupe to operate upon the patient when the microscope is not available? Do we say the person is not applying the principles of evidence-based neurosurgery? I don't think so. As I said before, if you look again at the building blocks, the best research evidence, surgical expertise, patient's values, we need to look at also the local settings, the context in which we are going to apply this. So therefore, maybe using the magnifying loupe in a setting where there is no microscope shouldn't be considered as suboptimal care being delivered to the patient. Another question, which, because we are talking about cervical spine research, is a paper which we published here. We happen to have been practicing in a setting where there was no intraoperative fluoroscopy. And we base our decision making using anatomical landmark, the carotid tubercle, to get the leveling and localization of the level in which the patient had the injury, and we were able to do good cervical surgery, good cervical spine surgery with good outcomes comparable to settings where the fluoroscopy is. I'm not saying we don't have to, the fluoroscopy is the standard of care, but if it is absent, what do we do? Are alternative methods, is somebody using alternative methods said not to practice evidence-based medicine? Do we say it is not good practice, or do we say it is unethical? I think we can discuss this after my presentation. So the application of guidelines in LMICs should be contextual. We have to consider the setting. We don't just have to focus on the best research evidence. We need to look at the surgical expertise. We need to look at the patient values. But most importantly, we need to look at the context. As the previous speaker said, most of the burden of neurosurgical disease are found in LMICs. And we know in LMICs, there's inadequate patient, human, financial, and physical resources. So when we are challenged with patients or patients with emergency situations, do we wait to institute the standard of care, or do we deliver the care to the patient based on what we have at hand? These are things I think we can discuss in the next few minutes. Thank you so much.
Very good. Ignatius.
Very, very, very good presentation. I mean, that you went really to the point we need to discuss, and maybe in the future to inspire other papers. So let me see if I can launch here your questions.
Yeah.
So can you read them?
So the first question, I'm seeing the question. So the first question is it possible to practice evidence-based medicine without randomized clinical trials? A is true, false, and then C is I don't know. Well, there's a fallacy that people who don't understand the concept of evidence-based neurosurgery feel that it is based on randomized clinical trials, but we all know that there are certain pathologies in neurosurgery where decision can never be based on RCTs. It's not possible to conduct RCTs because maybe they are very rare pathologies. We need a very long time to accrue a good sample size to be able to do so. Such decisions can be based on observational studies or even case series. So evidence-based medicine can be practiced without RCTs. The second question is, the RCT is excellent for answering all research questions in neurosurgery. Also, this isn't true. There are situations where we cannot use RCTs. Okay, I mean, if you know, I mean, there are certain situations where we cannot randomize patients into group A and group B. So we can also base our decision on observational studies. Question 3, in the hierarchy of evidence, meta-analysis of RCTs are ranked at the top of evidence. This is true. We know meta-analysis, systematic reviews and meta-analysis of RCTs, they are the pinnacle of evidence-based medicine or neurosurgery in particular. But as I said before, if it's not possible to have RCTs, we have to move to the next level of evidence. We step down to observational studies. If observational studies is not possible to have, there are no observational studies. We can even be based on expert opinion. So every piece of evidence is important in making decision in the patient. The fourth question is, evidence-based medicine disregards expert opinion. Many people feel that evidence-based medicine does not have room or does not create space for expert opinion. This is not true. As I said again before, it integrates base research evidence, surgical expertise, experience, and judgment, patients' values, preferences, okay? And then we have to consider the context. So again, evidence-based medicine is inclusive. It doesn't exclude certain aspects. So I think that's all.
These are the answers that we got from people.
Yeah.
Brief comment. Question 1.
Yeah, I think the answer is correct. We can practice evidence-based medicine without the RCTs here. The RCTs is excellent for answering all research questions. This is not true. This is false. Okay.
Okay.
As I said, yeah, in the hierarchy of evidence, meta-analysis of RCTs are ranked at the top. This is true, as I explained before. Evidence-based medicine disregards expert opinion. This is false. As I said again, we need, although expert opinion is found at the base of the hierarchy, it doesn't mean that it is not part of the evidence. It is very important in the evidence hierarchy.
Very good. Aiko.
Ignatius, what I really liked is you stressed the evidence-based medicine, the microscope and the loupes, and I think we should see it worldwide. For most surgeries, you don't need a loupe, you don't need a microscope, you don't need a fancy CT scanner. What you need is education. That's why we are here with CSRS, partnership, fellowships, learning how to put screws without X-rays, how I just have been in a very great time in Namibia, and I've seen so much great techniques. So you need really education, the skills. Sometimes a skull traction is the best thing you can do than doing a crazy surgery with a roboter in a night shift. So I think it's very much about education. And one thing also I want to stress is for evidence-based studies, what I have started to do is I'm reading these studies and I only look to the conclusions, what is not recommended based on the randomized control trial. So I'm looking for what is really medical nonsense, what is not recommended, what is wrong. And I think when looking for this, then we can find you a better concept given the settings that you have. Yeah. So I'm looking for what is not recommended based on the randomized control trial, because there are many ways to the goal, and many ways can be correct. But the randomized control trials, they should show us what are really wrong ways, and I look for this.
Okay, thank you.
Very good. So I think we can discuss at the end, and just to keep with the pace, and to have a real feeling of what's the current practice in Southern Africa. We are pleased to have Alex van der Horst from Namibia. He's a consultant spine and orthopedic surgeon, and despite his young age, he has done already some pioneer work in Namibia. He created Department of Orthopedic Surgery at the University of Namibia and started the first and the only one regular spinal service for state patients in Namibia. He's founder of the Namibian Surgical Society, and is presenting on the importance of skull traction in the management of cervical trauma, the Namibian experience. Please, Alex, it's a pleasure to have you here. Can you share your screen, please?
Thank you. Thank you for the introduction. I had the privilege of having Haiku visiting me 2 weeks ago in Namibia, and we had a great time working together and exchanging techniques. So for the last 7 years, I have lived and worked in Namibia, and in this time, I have dealt with a lot of spinal trauma. So a bit about Namibia. It's a vast country, 825,000 square kilometers, with a very small population, having 2.54 people per capita per square kilometer. So it's a very, very vast country. But we do have a very high per capita motor vehicle accident rate, actually the highest in the world. And there are multiple reasons why we have so many car accidents. Every week I see 2 to 3 referrals for spinal trauma cases, of which I definitely operate one each week. So what are the causes of spinal trauma in Namibia? Well, the demographics of spine trauma is, I think, similar in most African countries, but we have a few unique situations in Namibia in that there are vast distances between towns. Often the first responders are poorly trained. There is no concept of ATLS. Patients can end up after an accident on the side of the road, waiting for hours and hours until anybody arrives at the scene of that accident. We have a lot of animals on the road, like you can see in the image, the cow, and we also have what we call the rollover accidents. So this is an interesting accident we find with tourists who arrive here. They're used to driving in Europe, and they rent a big 4x4, and they go on a curve, and they roll their car when they slide, and they end up with uni and bifacet dislocations. Otherwise, we have interpersonal violence, falls from horses, palm trees, mining accidents, and normal demographics that we find in Africa. So just briefly putting our road accidents into perspective, in Namibia, we have 6 times more deaths due to motor vehicle accidents per 100,000 than in Germany. So you can see 4.6 versus 29 deaths per 100,000. Mostly we see high energy head-on-head collisions with both vehicles bursting into flames, and obviously the patients all dying. If the patients do survive, they are usually heavily injured, and with the vast distance between accident site and the hospital, one should have appropriate care and early appropriate care. So just briefly, pre-hospital emergency management is similar all over the world, and that we follow the ATLS principles, and we do not treat the neck until we've dealt with life-threatening injuries, chest and abdominal injuries. We tell people that if the neck is in an abnormal position, just putting it to the normal neutral position and then stabilizing with a stiff neck collar is priority. In Namibia, we still have the soft collars being used everywhere, which is totally wrong and offers no proper support for a neck. You need to have a Philadelphia collar or a stiff neck collar or a head block or a Miami J type of collar to safely and securely stabilize an unstable neck. But soft neck collars are all that the people arrive in. I don't know why. We've tried to change it, but for some reason they get kept on being ordered. Once they get to emergency unit, appropriate evaluation, x-rays, CT scans if possible, and obviously if there's neurological deficit or unstable spine, we would say application of Cohen's calipers and urgent referral. Commonly, we see uni and bifacet dislocations, and intuitively, these injuries would benefit from early appropriate care. And this involves the medical and surgical interventions to lessen the secondary spinal cord injury. The primary injury has occurred. We can do nothing about that. But the ongoing pressure of a dislocated neck on the spinal cord can be, or should be, reversed as soon as possible and not wait until the person arrives 6 or 8 or 10 hours later at the next referral center. Advanced imaging. In the big centers, we've got advanced imaging of the spine. And although CT and MRI scan give excellent visualization of the injury, it should not delay the necessary treatment. And we all know the necessary treatment for this is Cohen calipers or skull traction. This is what the patient needs, not an MRI scan. The MRI will not make the patient better. The contraction will. So the goal is to get the management in the trauma unit to be Cohen's calipers as well. And most doctors are comfortable with inserting an intercostal drain, inserting a CBP, and without thinking twice about it. But for some reason, when they get to Cohen's calipers, they panic and they say, no, I can't do this. We need a neurosurgeon or an orthopedic surgeon. In my spinal rehab unit, the nurses themselves apply the Cohen calipers when a patient arrives or needs it. But any doctor with a bit of training should be able to comfortably perform the procedure. So let's briefly look at the indications for skull traction. Firstly, it's for the reduction and the conservative treatment of cervical dislocations, uni and bifacet dislocations. You can stabilize a fracture as well while waiting for theater or during transfer. Conservative treatment of cervical fractures, for instance, your traumatic spondylolisthesis of the axis or Hangman's fracture, is a proper way of treating with those. 90% of those injuries we treat on Cohen's calipers. I have always regretted not applying Cohen calipers. I have never regretted not applying them. Surgery is so much easier with a reduced spine. It takes a lot of your stress away. It gives you a lot more comfort in theater. You don't have to worry if you're going to do open reduction. So I always apply Cohen's calipers whenever I have the opportunity. Even if the patient is going to theater in 2 hours' time, I will still apply that and gently reduce the dislocation because it makes my surgery just so much easier. When there are indications, there are also contraindications. And the contraindications are children. They cannot handle the application of the Cohen's calipers because it's an awake procedure, local sepsis, skull fractures, and a certain of the Hangman's fractures, your type 2A, Levine-Edwards, we should not be giving excessive traction on. If you're going to do immediately MRI scan, you don't want to apply because they're made of metal and they will go into the magnet of the MRI scanner, or if it's going to delay your theater. So if you're going to go straight to theater, then you should not apply the Cohen's calipers. There are also some complications that we can get with the application of Cohen's calipers, vascular bleeding from the temporal artery. You can get pressure sores if your weights, your pull, your vector is too much downwards. You can worsen your neurological status during the reduction. And that's why you need an awake patient. Or you get squinting from the 6th cranial nerve fallout, and then obviously local sepsis can also occur. How do we apply the Cohen's calipers? Well, firstly, we explain the procedure to the patient. Please note that this image is how you should not be applying the Cohen's calipers. As we can see on this image, the Cohen calipers is applied far too anterior. It's pulling on the skin, and the skin is not shaved, so everything is wrong there. This is not how we want it. So we explain for the patient what we need to do. We shave the hair above the ears and prepare the skin We try and avoid the temporal artery. And where do we insert it? Well, distal to the equator of the skull. This is because there's the increased pull-out strength at this level, 1 finger breadth above the pinnae, in line with the auditory meatus. That is the standard where we apply these pins. If you push or turn the pins too hard, or you put too much weight on, it is possible to bend the pins or push them actually right into the skull. Further, once we've cleaned the skin and we have shaved the hair away, we infiltrate with a bit of lignocaine the skin, and importantly, right down onto the periosteum. So you want to inject 4 or 5 mils of lignocaine over that area on both sides to make sure the person does not feel the insertion of the pins. You don't want them making fast movements. You make small incisions after 2 or 3 minutes to insert the pins. And then you, with your spanner, it's usually a 13 size spanner, you tighten the pins and they carefully go into the skull. Then you tighten until it's firm, and you must make sure that with a bit of pulling on it, that it does not move, that it was well embedded in the pin, in the skull. And then you dress the pins with betadine solution, iodine solution on a gauze, you tie your ropes, and then you attach your weights as needed. Some extra tips is that you should use a firm double mattress. So you've got them at 2 different levels, so you can put the head more into extension. So you can manipulate your cones and a bit of a pillow underneath the head to support it. You nurse with the bed slightly head upward, so that the patient's gravity is pulling the patient downwards and your traction is pulling it this way. You put the person level or other way down, you end up pulling the patient off the bed. We use a swan neck, that is to put the pulley on where the rope will go over. And if you use a square one as opposed to a round one, then it doesn't toggle when the weights are too much. If you want more flexion, you put the pin slightly more posterior, or you raise the angle, the vector of the traction, and then you get a bit more flexion, because during the reduction, at some point you need more flexion, at some point you need more extension, and you need to be able to change those things. If more extension is desired, you place your pins more anterior on the skull, or use a double mattress. And then once the traction is on, you remove the collar. So your reduction technique is as follows. We give some very light sedation. You actually want an awake patient that can give you feedback, because if they are having a neurological worsening, you need to stop your traction immediately, and that's the indication to most people go for open reduction. So you give a bit of benzodiazepam, maybe a bit of dormicum, midazolam, and then you speak to the patient, explain what you use. And it's active technique. You are applying weights sequentially and watching what's happening and repeating x-rays every few minutes to see what is the progression of your reduction. You use image intensifier, that means your x-ray machine, a mobile x-ray machine. You start at inflection, and then you start with 5 kilograms of weight for the craniocervical junction, for your skull, and you need to image the craniocervical junction to make sure there's no C0, C1 dissociation, which widens as soon as you apply some weights. And then we increase the weights with 1 kilogram increments, and we watch what happens. Again, once we are giving on the weights, we need to watch what is happening at the C0, C1 level, and that we are not distracting it too much. Once the facets are cleared, you extend the neck without removing the track, remove the head support, and you drop the pulley to increase the extension. And then if the reduction is done, then you remove the weights until you're down to your 5 kilograms. So just briefly to show you the progression. So this is the dislocated bifacet, which we don't want. And as we increase the weights, we can see how it gradually moves along, and how it's now sitting with a perched facet. And every time we're asking the patient how he's feeling, is the neurology worse, better? And there it's just slipped over, but it's still not in a good position. It's still in kyphosis. There's no lordosis there. And now it's looking better. And then we get a bit of extension. And then we drop the pulley. We bring it lower. And that is what we have before. And we've got our after reduction. And if it was your neck or your family member, you would want to go from this before reduction to the after reduction in the fastest possible time. And this is why we cannot, if we have a patient with a dislocated neck sitting in a place like Rundu, which is 7-8 hours from me in Windhoek, we can't say no problem, put them in the back of the ambulance, we'll see them in 8 hours time. This procedure has to start immediately to minimize secondary spinal cord injury. So getting back to immediate reduction versus MRI scans, often in low and middle income countries, we do not have the luxury of an MRI scan, but there are some centers where it's available. And just to recap, that reduction, that means reduction with the Cohen's calipers, gives us canal decompression as a form of treatment. We're actually making the person better. MRI is only investigation. It's not doing anything for the patient. It's just the investigation. It's nice to know, but you want to do what's best. So should we do a pre-reduction MRI scan? This is controversial. Those for a pre-reduction MRI scan say reduction in the presence of an extruded disc will possibly result in displacement into the canal and cord injury. That means you've got a neurologically normal person, you reduce them, and suddenly there's disc in the canal, and you cause paralysis, and there's a lot of fear of this happening. But in the literature, this is so rare. In the cases where it did happen, these people were under full anesthesia or obtunded. For against MRI scan, we don't know how much disc is dangerous. 1 millimeter, 10 millimeters, how much disc is actually dangerous. Will delay in getting scans, plus decision to delay in favor of reduction on questionable criteria. Initial reports of catastrophic deterioration when patients not examinable or anesthetized. So, almost in summary, who gets reduced and who gets an MRI scan? Okay. Urgent reduction with sequential weights, what are we advocating here, and neurological monitoring in the wake. Alert patient prior to MRI has been shown to be safe and an accepted protocol. In many first world centers, it is the standard of care. In the Charité Hospital in Berlin, 2 hours unreduced is a medical legal limit. So they are forced to immediately start this reduction procedure. So our guidelines are basically, if the person's got complete neurology, as in there is no neurological power, no reflexes, no sensation, we reduce the person first. If there is incomplete neurology, we also reduce first. If the person is totally intact with a bifacet, which is very, very rare, then it makes sense to do an MRI scan first. If the person's obtunded due to low Glasgow Coma scale or possible alcohol, then it's also wise to do an MRI first. Anytime during a reduction, if there's any sensory or motor changes, we abort the procedure. In summary, we follow ATLS principles. We identify the spinal cord injury during the initial assessment. Once our life-threatening injuries have been identified and treated with chest drains, and et cetera, et cetera. By default, we need to immobilize spine trauma, the spine in all trauma patients. So it's easier just to assume every patient's got a spinal cord injury when you've got a heavy trauma patient and protect the spine. Protecting the spine is priority. Clearing the spine is not a priority. We want to maintain core perfusion. Just like with head injuries, we want to prevent a secondary head injury. With the spine, we also want to prevent a secondary spinal cord injury. We want to do whatever we can with medical treatment and surgical treatment to maintain good perfusion. Stable injuries generally get treated with stiff neck collars. Unstable injuries or with neurological fallout, we apply cone calipers immediately. We need to order appropriate imaging, not waste time when the patient needs care, and do MRI scans when the person actually needs cones applied, and then early referral for the definitive care. Thank you very much.
Very good.
Oscar, you have to remote unmute yourself.
I don't know. Yeah, okay. So thank you, Alex. Wonderful flavor of what's going on in Africa. I'm going to launch your questions. Can you read them, please? And people can vote, and then we comment at the end.
The correct positioning of placing cone calipers in cervical fractures is which of the following? In line with the external auditory meatus, anterior to the external meatus, posterior to external auditory meatus, or is it irrelevant?
Second question.
The appropriate weight for maintaining alignment after closed reduction prior to surgery is which of the following? A third of the total body weight, up to the surgeon's discretion, yet not exceeding 2/3 of the body weight, 2.5 kilograms for the head and 0.5 kilogram level for the level affected. 0.5 kilograms for the head and 2.5 kilograms for the level affected. Question number 3. The following is a contraindication for the use of Cohen's calipers. Levine-Edwards type 2 traumatic spondylolisthesis axis. Levine-Edwards type 2A traumatic spondylolisthesis axis. A C5, C6 unifacet dislocation with a pedicle fracture in C4. Flexion teardrop injury at the C5, C6. Awaiting theatre. There should be a fourth question.
I'm afraid not. I'm sorry.
Okay.
Okay, so just share the results of polling systems.
So the first one is seems to be correct. In line.
So you did a great lecture. 100% agreement. Number 2.
The second one, it's a bit of a trick question, but it's the appropriate way for maintaining alignment. It's not the initial to reduce it. Maintaining alignment after you've done the reduction. It's actually number C.
Okay.
And this one is also correct. 100% type 2A. We would not apply traction. This could worsen this injury.
Very good. Thank you.
Alex, it was a great lecture. Really appreciated this. And you mastered the caliper traction technique. Can you give a recommendation in your hands? How long does it work? So it works for remote injuries, maybe 2 or 4 weeks also. So what is your recommendation if the patient coming 4 weeks after having any kind of injury, and what are you doing for them?
So I've had a couple of neglected injuries where the injury was missed because the person did not arrive to a hospital, didn't have x-rays, lay at home, has kept his collar or had a collar on. And I've had people arriving after 1 week, 2 weeks, up to 3 months. Every one of them, I actually used skull traction initially. And even in the person who had a 3-month history of a unifacet or a bifacet dislocation, it made the surgery so much easier. So I would say in more than half of them, it actually reduced. And the other half, it stretched it out very well, that my surgery was a lot easier. And with anterior release, I could then do the surgery quickly. But I would advocate at least a trial of 1 week of traction in the ward, gradually increasing the weights. And in our country, it is quite easy to admit a person to a government hospital where the costs are relatively low and apply traction. I can understand in New York, you can't admit someone and just say, oh, we'll put you on traction for a week because the costs are massive in a private hospital. But we've got that advantage that the patient are quite patient. They are just happy for the care they're getting, and we do that. And definitely, I'd rather have a slow reduction of a 3-month-old dislocation than try and fiddle around and very quickly do that. I would, of course, preoperatively or pre-traction apply, do my CT scan and an MRI scan to assess the integrity of the disc, see if the facets are ankylosed or what is happening. But you can't do harm by gently putting on traction, getting that thing reduced to a better position.
Good point. Yeah, good point.
Very good. So let's going on. We can always at the end come back and discuss. So next I have Noor Maria. She's a young Pakistan neurosurgeon from Punjab Institute of Neuroscience in Lahore. Taking the risk of positive discrimination, I would like to congratulate her for resilience and talent to become one of the few accomplished female neurosurgeons in Pakistan. She will talk about the cost effectiveness of surgical management of traumatic cervical spine injuries in low and medium income countries. Please, Noor.
Thank you so much, sir. First of all, it's a huge honor for me to share my very humble work at your very esteemed webinar, the one we usually follow regularly. So it's a big thing. I'm really pleased, and thank you so much for the very nice words, sir. It means a lot to me. It means a lot of motivation, especially since I belong to low middle income countries. So that means a lot to me. Thank you so much, sir. It's big for me. Thank you, sir. My work is very a humble effort, along with my other friends from the low-middle income countries, so that we could gather as much data as possible. So it is basically cost effectiveness of surgical management of traumatic cervical spinal injuries in the low-middle income countries. Sir, as we all know, that low-middle income countries are, as per defined by the World Bank Group, countries with an income economies of just $1,006 to $3,955 GNI per capita. So this is the whole map of these low middle income countries, as depicted by with the color orange. So, sir, according to the WHO, about 5.8 million die from trauma each year globally. That surpasses more people who die from the HIV, AIDS, and malaria combined. So that's a huge thing. The road traffic accidents alone account for about a quarter of trauma deaths. These people who survive their traumatic injuries, unfortunately, are left with a lot of disabilities that usually make them incapable of doing the normal routine of their life, and that creates a lot of trouble for them and for the caregivers, and actually add up to the cost-effectiveness of several treatments and also economical burdens in our countries. More than 90% of deaths due to trauma occur in low and middle income countries. That's another unfortunate thing. And another thing I want to point out is that there's a lack of data and lack of research from low middle income countries in trauma, which are the most affected ones in the whole wide world. The mortality rates from injuries are also higher in people from poorer economical backgrounds, like in the low middle income countries. These are also more common in low middle income countries because there are several factors, but includes that poor roads in our countries. Several areas do not have a proper road system, and there's a lot of two-wheeled vehicles, including bicycles, as well as other cars and everything like that. People are not quite experienced before getting, some formal driving test or things. They usually come on the road and drive. Underage drivers are also very common, and also thrill driving. The one-wheelers are very common in the teenage group, and that's very unfortunate because they usually succumb to their injuries, or they're left with crippling disabilities. So the operative treatment consists of, obviously, as we know, the decompression of the neural alignment, stabilization of the spine, either through anteriorly or posteriorly. That's a huge thing. Non-operative treatment consists of bed rest and obviously bracing the spine, which includes lying supine without walking or wheelchair use until the 3 months period is over and the fracture reunion has taken place. Ambulation, which are physiotherapy, is not provided during this period of bed rest. So it is usually basically not just a bed rest, but also those problems that can arise due to bed rest and be respiratory complications. Many people do succumb to their respiratory infection, and this is a very critical period during that whole, conservative treatment that adds up to several problems. Bacteria, as described in the ISI reports, include in general an intervention is considered to be cost-effective with either. It should be noted it is either not. We do not have to satisfy both of these conditions. We should satisfy only one of these. Either the intervention dominated other relevant strategies, or the intervention causes less than 20,000 pounds per POI. That is a quality life. The data from this study has been included from low-middle income countries that include Pakistan, Afghanistan, Iran, Bangladesh, India, Egypt, Iraq, and Syria. We retrospectively studied about 240 patients with cervical spinal injury, 30 patients from each of these countries. Half of them underwent surgical management, half of them were managed conservatively. In our data, we excluded the patient with other systemic injuries on presentation to the bias and everything that may affect the results. For cost-effectiveness analysis, we calculated the DLIs, cost per DLI, and DWs of the patient. So I would like to share the brief description of DLIs. That disability just life year is a measure of overall disease burden, expresses the number of years lost due to ill health, disability, or early death. Cost DLI averted is basically the outcome measure that we need to apply in the cost-effective study. It is to present the amount of money required to avoid losing 1 year of healthy life. DWs are disability weight, is a weight factor that reflects the severity of disease on a scale from 0, that is perfect, to 1, that it actually indicates this. Methodology DLIs were calculated from the CVR Tuft. This is an online software which is being funded by the Bill Melinda Gates session. Disability weights are developed by the Global Burden of Disease Studies for the LMIC's Disease Control Priority Network has proposed a cost-effective threshold of $200 per DLI averted. So that's what we, which was our outcome measure. That's how we had to compare. So estimated cost of surgical management and conservative management was calculated for all of the low-middle income countries. As I have told you, the outcome was by cost per DLI averted. The primary outcome. That is the amount of money required to avoid losing with So based on our data from low middle income countries, cervical injuries comprise about 23 to 26% of the spinal injuries. The average age of patient is 28.5. This is very noteworthy because this is the main earning age group. So this is very serious, and it is also in the male population more common. So this is a very serious point. About 45 to 45.6 to 51.3 undergo surgical management. The estimated cost of surgical management varies from public sector to private sector. So here I want to add up that in public sector hospitals, it depends. Sometimes we do have limited amount of funds that we can provide free treatment. We also have charities, and in Muslim countries like in Pakistan, we do have a zakat fund. We have, or some people usually give donations or something like that. So on a very limited scale, we may be able to provide free treatment, but it is not applicable for everyone. So it is just a very limited amount that a few patients can avail. In the low middle income countries, public sector hospitals do have a provision, like I've said before, in cases where hardware is not available. In other cases, we do have some local funding in hospitals, so we can just provide other hospital treatment for free, but we cannot provide the hardware. So in that case, the price range for hardware for locally manufactured hardware is about $95 to $170 for locally manufactured implants. The imported implants are even 2 to 3 times higher in price. And for surgical cases, more to add on that hardware implant price, we have to add charges for the length of stay in the hospital, the additional post-op imaging, the medicine if they are not available in the hospital, and patient has to buy. So for what we have calculated, a minimum fee additionally to that, the operating fee is usually very minimum, not very much. So there is the other expenditure can be about $155 to $180. That is in addition to the implant price that usually between $95 to $170. The expenditure for conservative management is minimal and accounts for expenditure in terms of length of hospital stay. In public sector hospital, the patient has to pay only the bed charges and payment for investigations and maybe medicines if they are not available. And what we have calculated, it ranges between $125 to $150. This is also because surgical management can lead to a variety of neurological outcomes depending upon the severity and the type of injury incurred. We divided patient into 3 subgroups that were either neurologically improved or neurologically intact, distal fractures and quadriplegic. So in neurologically improved surgical treated patients with cervical injuries who improved to Asia D to E. And this group actually represent how surgery can actually offer substantial improvement and help the patient regain the walking ability. The DW, as I have explained before, the motor impairment with operative surgery just reduced to 0.061, while for non-operative cases, it rises to about 0.4. And that's very high, that's approaching 1. Neurologically intact with unstable fracture for surgical versus conservative treatment for operative fractures, it decreases to just 0.005, while for non-operative one, the lower back pain and neck pain, DWs rise to 1.3. In quadriplegics, in those patients who the outcome was quadriplegia, that was they were not better than Asia C. So basically, Asia C patients cannot quite do not have a very high level of quality of life. They cannot care for themselves much or ambulate independently. So in that case, operation would decrease DW to 0.5, while non-operative is just 0.7. Not a very huge difference, but still there is. For neurologically improved patients, we calculated the cost per DLI averted was about $50 to $97 per DLI averted. For neurologically intact patients with unstable fractures, neurologically, that was about $54 to $102 per DLI averted, and surgery for quadriplegic patients was about $90 to $148 per DLI averted. All 3 are less than $200 per DLI averted, which was our standard of comparison for cost effectiveness as per applied for the low middle income countries. So actually, surgical treatment was found to be cost effective for all 3 outcomes. In fact, although it was the most cost effective for those who were neurologically improved, and then for those who were neurologically intact, and lesser to a lesser degree for the quadriplegic one. But if we just ignore this economical, cumbersome terminology in very shorter, simpler, and better way, surgical management is best, as well as the most cost-effective one for neurologically improved patients and intact group as compared to quadriplegic. But the very unfortunate thing is, in our part of the world, people cannot afford even this meager amount of money. This is the affordability matter is very serious. So even though the surgical management is very cost effective and in the long run will be beneficial, but for the very start, if we cannot provide them free treatment on all those patients in which it is not possible for us, even that meager amount of money that I have mentioned is not affordable by most of our patients, and this is very unfortunate. While surgical management is cost-effective in public sector, is not much high, but with the given financial condition of individuals, even this is not affordable, and in public sector, it is prudent to prioritize patient for surgical treatment. So we conclude that in the public sector, surgical treatment has been found to be cost-effective for all the three groups. It is the most beneficial and cost-effective for neurological improvement in group. Yes. Yes, sir.
No, go ahead, please. Sorry.
The overlooked important areas of management of cervical spinal cord injury in no middle income country include the pre-hospital care. I would like to emphasize in this point because many complications can be actually avoided during the pre-hospital care. We do not have any EMS system, and most of the time the first responders are the passers-by, especially in the periphery, where usually the passers-by just to go and shift the patient and manage, and they do not have any idea how to stabilize the neck and how to log roll and how to test the patient. So many complications can arise, particularly at that point. And even there are many delays of patient transfer. So this is something that is very important and can be very cost effective in the long run if we just train our people from the school level to perform a proper pre-hospital care and transfer of the patient to the hospital. The other thing is we do not have rehab facilities, and many patients do succumb to their complications, especially the bedridden ones. So this is very important, and that adds to a lot of ALIs. This is very serious. The third thing is awareness campaign in order to minimize trauma. I have presented my work at ICRA in 2019, which was about minimizing how can we minimize trauma. So basically, we do not have much, people do not have much awareness about how to avoid and minimize trauma, and it can be very cost effective as well if we just implement some very few precautions, including like wearing of helmets and safe driving, safe drivers, safer roads, and just to try to avoid, we have usually like in our country, people about 4 to 5 people ride one motorbike. We have to reduce the number of our riders. The house should have, door-to-door campaigns for awareness and training for disabled people, lack of vocational rehab and opportunities for disabled. If we just provide them vocational rehab and opportunities, then they will be able to be economically, more, they will be able to generate their own fund. They will be feeling themselves to be useful for the society. That will reduce a lot of psychological trauma. And the third thing is that they will be very economically beneficial for the country as well if they are working. So again, pre-hospital care has been described before. We need to start mandatory training from the level of schools to have people perform the pre-hospital care. So this is very important. It's a malpractice lawsuits. The quadriplegia lawsuits are very well known, and even a few doctors have suffered from this. There's a very important, famous case of a doctor who actually caused quadriplegia in a patient with cervical injury while he was transferring him from the road. He found him on the road, and this was something that actually points out the importance of proper pre-hospital care and transfer of these patients. The role of social media as well as TV can play an important role in training people for pre-hospital care. There should be training videos and webinars to avoid complications during this important period. There should be a team of emergency response workers. In Pakistan, we had 112, but they do not perform their services in the periphery, the very far-flung area. The first responders are usually the fastest by. The lack of vocational rehabilitation and opportunities for the disabled, while the low middle income countries do have limited resources to provide benefits to the disabled community, there can be different vocational options for these patients depending upon their disability. Like nowadays, people can do online work. This is very common right now in Pakistan. If I'm talking about my own country, they can be employed to do some online type of work that can be very easy. I will explain it later. It includes call center jobs for patients who can speak. There can be teaching jobs for the patient who can speak and teach. that will help them to gain self-confidence to serve as a helpful person to the community as well as earning a living. This is the ILO skill development for persons with disability. That was a proposal by the ILO. Vocational training facility, this was a study by Stanford, and that's how they showed that how the goal of vocational training facility can be achieved through, this is the desktop type of training, a desktop type of job, like I have told before. The rehab facility, there's a lack of emphasis on the extremely important domain. In Pakistan and other LMIC, there are trained physiotherapists and speech therapists, but there is a lack of proper management to provide this opportunity properly and timely. It is an extremely important part of the plan of the quadriplegic that would ultimately help providing complication in this group of patients that may even pose a life-threatening condition at that it at not only quality of life but also actually years of life. So this is very important. Emotional rehab, as I have told you before, they need a lot of psychological support. Some research work of importance includes stem cell research in spinal cord injuries, as we all know, and functional electrical stimulation of spinal cord injuries. These are all research topics, how we can just put them back into motor activity. Awareness campaign to minimize the evil at the bird. With reference to my acronym 2019, we need to impose strict traffic laws. The use of double-wheeled vehicles should be discouraged, but because of financial issues, it's going to be banned. So we had just 2% per bike, a separate lane for them, and obviously winding one-wheelers. There are other domestic issues in the building designs of houses, especially in rural areas where the rooftops and stairs are not being harnessed, they are not being protected with any railing. And this is very, very bad because a lot of patients we receive are due to falls, especially in pediatric age group. This is very common. This is very serious. This all adds up to the incidence of spinal cord injury, especially in the younger age group. So for budget allocation, we are where free treatment cannot be provided, there should be provision of charities and the cost points, provision of the use of locally made implants. This is very, very important because it can be provided. Subsidy on implants, provision of payment in installments, government can provide people loan, they can employ those people who have been disabled or their families, they can employ them and cut the installment from their pay. This can be very easily provided. This is just a management and policy thing that should be implemented and this should be suggested. And for rehab, promotion of welfare workers and volunteers. I thank you again for listening to me and thanks a lot again for inviting me.
Thank you, Noor. Okay, so we're going to launch here some of your questions, please. Can you read them, please?
Sure, sir.
Noor?
Yes, sir, thank you. Question number 1, in the low middle income countries, surgical management for cervical spinal cord injury is A, cost effective, B, not cost effective, C, none of the above, D, no idea. Question number 2, according to cost effectiveness criteria, the NICE report and intervention is cost effective if A, the intervention dominated other relevant strategies in terms of cost and resource use and more clinically effective, or the intervention cost less than 20,000 pound per quality adjusted life year KLI. B, the intervention dominated other relevant strategies in terms of cost and resources used and more clinically effective, and the intervention cost less than 20,000 per KLI. You have to just think that in A it is or, and in B you have to satisfy both of these conditions. In C, only if intervention dominated other strategies. In D, only if the intervention cost is less than 20,000 pounds per KLI gained.
Okay, so this is the voting. People think it's cost effective, as you nicely argued. And question number 2, people think B, it's the most appropriate. Can you comment? Noor?
Hello, sir?
Yes, these are the results. So,
okay, yes,
cost
got
effective,
it.
as you nicely showed. And for number 2, most of people think B is the most appropriate answer.
Oh, okay, sir. Well,
very good.
It was.
So I think I'm sorry. I think we need to move on. We are running late to our next speaker. It's a pleasure for me to introduce one of my dearest friends from northern Brazil, Ronaldo Farias. He's a professor of neuroanatomy at the Universidade Federal de Paraíba. He's head of neurosurgery at São Vicente Paulo Hospital. He served as a past president of Brazilian Neurosurgical Society. Most of people don't know, but the Brazilian Neurosurgical Society is the second in the world in numbers of members. And with widespread recognition, Ronald has been one of the most dynamic presidents ever of the society, with enduring work on organizational and educational projects. He has straight collaboration with the national industry to come out with cost affordable implants for spine surgery. So I invited him to talk about low cost cervical implants, a collaborative effort with national industries in Brazil. Please, Ronald. Ronald, unmute yourself, please.
Are you listening now?
Yes.
Yeah, we are listening. Yeah, please go.
Okay. Oscar, thank you very much for your invitation and for your kind words. Good afternoon, everyone. I'll try to talk about how to do affordable surgery, spine surgery in low and mid-income countries. So I have chosen some questions. How to perform more cervical spine surgeries in developed countries? Are surgeries exclusive for large and high-cost hospitals? And the costs of implants are reasonable? We try to answer these questions along the lecture. We live in Brazil. As someone knows here, Brazil is a continental country with more than 200 million people. And our health system consists of two parts, a private one and a public one. The public one we call SUS. It's a unified system that attends about 7% of the population, while the private system, 30% of the population. Our annual budget is about $170 billion. But instead of this inequity between numbers about population, regarding population, the budget is almost the same. And that's challenging for our patients in Brazil and for the doctors to equalize these two systems. When I give some lectures and when I teach my residents and fellows, I try to teach how to deal with the public system, because in Brazil it's easier to do the practice in private hospitals, because the hospitals in Brazil are of a high level of excellence. But the problem in Brazil is in the public system. And so we have we have the same budget for both the public system and the private system. So we need to do more spine surgeries for more patients with the same budget. The most principal cervical spine surgery are degenerative disease and trauma diseases. Among the degenerative diseases, we have 1 or 2 level ACDF, the most common, multi-level ACDF, and the posterior surgery. Both and trauma, 1 or 2 level ACDF, corpectomy and fusion, and posterior surgery. When you are trying to do a cheaper surgery, a more affordable surgery, we have to think about not only the economic issues, but also the medical issues. So when we choose the approach and when we perform an anterior approach, it's cheaper than a posterior approach. So I try to choose an anterior approach for 1 or 2 level disease. Try to do a more direct surgery with minimal dissection and perform a good hemostasis because of to avoid a bleeding complication. Other issue is to retract only at the point of the surgery. When you do large dissections, you include more risks and you perform a larger surgery that's sometimes not necessary. Obviously, when you are choosing the implants, cages alone, standalone cages with plating, with locking system, is cheaper than when you use cages and plating. So I prefer to use standalone cages to make a cheaper surgery. Instead of use BMP or other kinds of grafts, try to use local bone or iliac crest grafts or hydroxyapatite grafts, because they are cheaper than other grafts. And when we're talking about economical principles, it's very important in your city or in your state to make a kind of deal with the payers, insurance, or the state, that, and this partnership must include hospital, surgeons, and industry to achieve a reasonable price for not only the surgery but for the implants and the hospital costs. Bundled payment, in my opinion, is better than fee-for-service in this in cervical surgery. Try to choose low-cost implants and instruments, and we have done a partnership with the Brazilian industry to make implants more cheaper than before, and also to do instruments that the hospitals, the small hospitals, and the surgeons can purchase. We try to do most of the spine surgeries, including cervical spine, in one day, in 1 day stay in the hospital, to avoid long stay in the hospital, and obviously it's cheaper than a long stay. You don't need to do cervical surgery in big, large hospital and large facilities. You can adapt medium and small hospitals to do spine surgery. I am working now in a hospital that used to be a pain clinic and now is a hospital for spine surgery. And we perform surgeries and charge the patient on the next day. And so the cost of the hospital gets lower than before. What facilities, what equipments do you need to do a cervical spine surgery? Do you need all this stuff here, all these equipments? We don't need a special surgical table. You can do with a common surgical table. Skull clamp, I think no. Bipolar and yes, of course. But some equipments are not necessary indispensable to perform surgeries. Some equipments we can replace for other shippers and perform surgery in small and medium hospitals. Another issue is to reduce the set of instruments to the most important that we use, like curettes, dissectors, Carrisons, instead of have a large set of instruments. I'll show you guys the cost of cervical surgery in Brazil and instruments. In Brazil, the national industry, they sell surgical instruments with a low price than the imported ones. So this is the price of some instruments, and to have a set of cervical instruments, it's about $1,000 in Brazil. Here are the prices for surgery in the public system. For ACF surgery, a cage costs $2,700. That's the price that this public system pays in Brazil. And the cost that the public system pays in Brazil is about $600 for the public system. If you choose a private hospital in Brazil, a day hospital, the cost for 1 day stay is about $900. And if you choose a large hospital, you're going to pay much more. So that's the reason to adapt some in small hospitals to perform spine surgery. Então, as Einstein said, make everything as simple as possible, but not simpler. Some tricks to do a smaller, a cheaper and more affordable surgery. I'll show you now. Don't follow the steps. When you follow like a cookbook, you don't miss the steps. You avoid long termination. You can use a common table instead of a Mizuho table, as example. You can use pads instead of head clamp. A small incision makes an easier recovery. If you do a reoperation, do not try to open the same. Do a small incision above. You can identify the level of the surgery using a C-arm, but if you don't have, you can use a portable X-ray. Limit your dissection to the level of the surgery. Do not perform large dissections. Using retractors, try to use simple retractors, as we're going to show later. The placement of retractors. We use this GALP for long scoliosis retractions that avoid the use of casper retractors that is more expensive and needs a more room to operate. So we developed these retractors for long scoliosis retraction. This is the cloud retraction for interbody distraction. A set of cervical curettes, knives and sectors for the ligamentum. Try to do your best in this phase of the surgery, the hemostasis. Here are the national implants, cage and locking system. Some examples of spine surgery cases, 3-level cases using only a plate and iliac crest grafts, avoiding cages. This is an interesting case. Seems to be a very complex deformity case, but when you analyze, you just need to do a discectomy and a fusion at 2 levels. So we make a surgery simpler. Small incisions. Try to operate on the specific level. Here we have 2 levels, but the symptomatic level is this one. So operate on the specific level. When we perform a 3-level surgery, multi-level surgery, we avoid plates, and we have a great experience with multi-level surgeries using standalone cages. So you avoid plating, that's more expensive and demands more time of stay in the hospital. So another case of 3 levels. It's a trauma. In trauma, obviously, we need to use plates. But the message here is we can use the same budget in Brazil, attending more people in the public system if we follow some rules and make the surgery more simple than used to do before. That's my message. Thank you very much.
Thank you, Ronald. Very, very interesting overview of the strategy that you developed to make surgeries even cheaper. Heiko, do you have any comment, or Philippe?
Yeah, it was a very good stress that you stressed the cost of implants to make the steps simple. And I even would go one step further to say, really, take iliac crest, was done before. Nobody really suffered when doing this, and you get the best fusion in a disc space, and you can shape it also in lordotic, because an iliac crest can be more lordotic than any P cage on the market, and they have better fusion potential than the P cage. So I think the best interoperable graft, if you want to share some money, is a graft. What do you think about this? A graft and a plate.
I used to use a lot of iliac crest grafts and plating before, but nowadays I just use cages for all degenerative cases. But when I operate on trauma cases, I use iliac crest and plate.
Do the patients pay for the cages then? They have to pay an extra amount of money for the cage?
No. In Brazil, it's forbidden to pay extra amounts.
Good to know.
Very good. So we have different standards in different countries. So, to keep the pace, we go now to what I think it's a very important round table to discuss about implantless cervical spine surgery, with what are the suitable options. And to start with, I have Jamel Kitumba. He's a young, diligent, knowledgeable, and very promising neurosurgeon from Angola. He's currently my neurosurgical fellow here in Porto, and is presenting on the virtues of performing laminectomy alone. Please, Jamel.
Thanks, Dr. Oscar. Good afternoon, everybody. I can't express fully how honored I feel to be part of this CSRS webinar, and how blessed I am to be here to listen and to learn from so distinguished people. So for that, I'm very grateful. Thank you. Going straight to business, and just to give you a quick update, only this year, around 30 papers, 30 modest and very good quality papers were published on cervical laminectomy, just for you to see how pertinent and how debated this subject still is in these very modern and technological times. When we talk about multi-level spinal cord or multi-level nerve roots compression, cervical laminectomy is a well-established treatment. It's been done for decades, and it's based on the principle that it will allow spinal cord posterior migration away from anterior compressive structures. It will allow enlargement of the canal, and finally improves neural perfusion. Since the first series published that cervical laminectomy is proved to be a safe procedure with very encouraging results. If we see here, there is a quite variable improvement rates reported in the literature, but we can stay with more than 60% of improvement rates being published. And this is very good because we are talking about a very special population of myelopathic patients. And cervical laminectomy, all these authors concluded in the end that cervical laminectomy without fusion could be a very suitable option in well-selected patients, and we will see why. Even when compared to other techniques, when you compare cervical laminectomy with anterior approaches, with posterior approaches with fusion, standalone cervical laminectomy don't stay behind. It has comparable results in terms of overall improvement rate, even with acceptable difference on incidence of instability or postoperative deformity. Okay, this is very variable. But this is the big concern. When we do cervical laminectomy, how frequent we will encounter postoperative kyphosis. And actually, we don't know what is the real incidence of postoperative kyphosis. But I put this on purpose in this sequence. Maybe I omit something, but we can see here a trend. And from the early series, we can see almost 50% of kyphotic deformity to very recent series reporting almost none postoperative kyphotic deformity developing, even after long-term follow-up. And maybe this is representative of some growing knowledge or understanding of factors that independently are related with postoperative kyphosis. So this is the trick. Maybe we are coming near to a part that we understand how to predict or even to reduce the postoperative kyphosis incidence in our patients. Some factors are linked to the patients and others are related to our technique. For example, if we have a patient that has already a kyphotic deformity before surgery, he has an increased SVA, instability is already present before surgery, we cannot propose standalone laminectomy to these patients because we know what is going to happen. If we do an extensive laminectomy, very laterally, causing destruction of more than 50% of the facet joint, if we include in the decompressive levels the C2 or C7 laminas, this is very debatable, but they are linked to the increased risk of postoperative kyphosis. So when we are starting to plan to offer this procedure to a patient, we must never forget this basic knowledge of physiology and all the collected data around biomechanics. Remember the 3 columns model of the cervical spine that is different from the thoracolumbar spine. Remember cervical sagittal balance parameters and how all segments are interrelated and they influence each other. So in terms that when we go in and produce this disruption of these posterior elements, we will be able to predict how the patient will behave. So nowadays it's not acceptable that patients with multi-level spondylotic myelopathy or other compressive pathology go to operating room without having a thorough workup. So this patient must do a neutral and a dynamic flexion extension radiographs in ways that we can assess the range of motion to exclude any possible instability. And whenever appropriate, some patients must do a standing radiograph so we can assess the global sagittal balance and identify perhaps some deformity that has to be addressed more than the decompression. If we see, and still in the physiology chapter, there is some changes in the curvature of the spine that will happen with aging, and they are just an effort of the body to compensate and to try to keep or to maintain the horizontal gaze. This is a parameter that is very important nowadays, even in the clinical practice, to assess, and it is guiding. If we are not being saying too much, it is guiding some practice in the planning of the deformity correction. So when there is no clear indication for fusion, we have a patient that has a lordotic curvature, has no instability. We must make this effort to preserve these adaptive mechanisms and not to offer unnecessary stress to adjacent levels by performing a fusion. And when we don't do a fusion, of course, this is common sense, we are avoiding also implant-related complications. The other question is, okay, kyphosis is decreasing incidence, but it's still present, maybe in some settings it's still high, but how this kyphosis will impact in our patients' lives. And this is a series of 58 patients that were followed for more than 3.5 years after laminectomy. And 19% of these patients developed postoperative kyphosis. And luckily, none of them had a decrease in the outcome scores or a new neurological impairment that could be attributed to these curvature changes. And this lack of relation is echoed throughout the literature. We can see in multiple examples of many series reporting kyphotic deformity This is another example of 28% of patients that developed kyphosis after a short-term follow-up, this 48 months, but none of these patients had a decrease in their satisfactions. 80% of these patients, even those that had kyphotic deformity, were satisfied and would like to go through it again. So to this date, there is no clear evidence that supports this relation of kyphosis and functional or neurologic outcome. What about neck pain, axial neck pain? If we are in the scenario, we have done a laminectomy in a patient. Now he developed a progressive kyphosis. This is a relation that is very well studied in finite element studies, that a patient that have progressive kyphosis have as a result an increase in the cervical SVA, and this will push the posterior muscles of the neck through more stress, and this will finally result in fatigue and pain. This is very clear. This relation is very easy to understand here, but actually neck axial pain has multifactorial pathogenesis. It can be only attributed to kyphosis. It is related to the age, to whether or not patient had preoperative axial pain, is related to our surgical technique with the degree of muscle detachment during surgery. So this is another chapter in science that is not answered yet. So there is no evidence that established a real and clear relationship of kyphosis and axial neck pain. This is only causative. And when we have a situation where there's no clear indication or clear benefit of doing one technique over another, whether we will add or not fusion, patients' situation is equal. So it is, when we talk about low and middle income countries that have limited resources, of course, this information will be very helpful. If we compare surgeries that we use instrumentation and those that not, of course, instrumented interventions will be much more expensive. This will make laminectomy a very valid option for limited resource settings. And of course, this is not new, but is growing, and everyone should be always aware of the efficacy, the effectiveness of these new and least invasive techniques. They offer the maintenance of range of motion because they are based on the least destruction of posterior elements, limiting muscle disruption. And maybe some of these solutions will overcome some limitations that multi-level laminectomy carries. So it's difficult to always point to some ideal scenario, but of course, everyone must be conscious and responsible and try always to offer the best to their patients with the least, spending the least, as the previous presentations talked about. So if we have a patient that have multi-level compressive pathology, has a lordotic curvature, there is no clear kyphotic curvature, there's no instability in terms of anteroposterior translation or more than 20 degrees of range of motion, there is no sagittal malalignment, and perhaps the patient has some risk factors for pseudoarthrosis. This is, in junction, the best scenario to offer a less invasive surgery that is a multi-level laminectomy. This is debatable, of course. And just to wrap up, cervical laminectomy is, yes, a feasible and safe solution if well indicated. We can try to predict or reduce the risk of postoperative kyphosis. We understand that when it happens, normally it has not clinical implication, but we must be always aware of it and observe. We will be able to predict or reduce the more we understand the cervical spine biomechanics. In many settings, not only the low and middle income countries, but even in resourceful places, cost information is very useful. We must pay attention to this. And yes, we must choose wisely our patients so we can afford the more or the best from this procedure.
Okay, thank you, Jamel. It was a really nice overview of the topic. I'm proud of you. So I'm going to start your questions. Can you read them, please, very quickly?
Yes, the first one is concerning to laminectomy. Which of the following applies? And we will try to find here the true answer. First line is laminectomy is a safe procedure on patients with a straight spine. Line B, always consider fusion if one level kyphosis is present. C, consider fixation if more than 3 millimeters translation or more than 20 degrees angular movement is present. Or the last line is cervical SVA is under 40 millimeters is an indication for fixation. This is the first question.
Question number 2.
For the second, still concerning to laminectomy, which of the following applies? First, post-laminectomy kyphosis is the major cause of neck pain. Late onset of kyphosis, the unique cause of late neurological deterioration. C, preoperative kyphosis is not a predictor for increased kyphotic deformity, or if evaluation of horizontal gaze parameters is of great help on preoperative planning.
Okay, just close the voting and sharing the results. So can you comment? Question number 1.
Yes, for the first one,
it
was very clear.
Okay. Question number 2, it's 80% thinks it's D. Okay.
Very nice.
Okay,
Very
so you
nice.
were a great teacher. So I think we need to move forward, and it's my pleasure to introduce you the next speaker. It's a very distinguished neurosurgeon from Porto Alegre, Brazil. Luis Carlos Alencastre is one of the most prestigious and respected neurosurgeons in Brazil. He's head of neurosurgery in different hospitals in his own city. He served as past president of Brazilian Neurosurgical Society. And concerning cervical spine, Luis is probably the most Dutch Brazilian guy I know, or maybe the Dutch are the Brazilians of Europe. And the reason of that is because Luis and some Dutch are the only surgeons performing regularly discectomy without implants. So listen to him very, very carefully. Thank you, Luis. Luis, you have to unmute yourself. Luis?
Okay.
Oh, can you start? Sorry, Luis, can you start again, please? Yeah, please.
Luis, you are on mute.
Oh,
yes.
And then, okay. I would just like to thank Oscar for this invitation and to my group for all the work we have done together. And showing here the procedure we do for discectomy alone, removing the nucleus and then the end plate and going on to remove the osteophytes, the anterior osteophytes. We do this carefully and thoroughly in order to allow some lordosis at the end of surgery, and then go into the lateral aspect, removing the osteophytes that may compress the framing. And we stop when we see the root is free. You can see a little bit on. that we can do this under the microscope safely, respecting the planes in order to avoid injury to the vertebral artery. And slowly we get to free the root in the anterior aspect of the frame. We have to just emphasize that what we want is to remove the osteophytes in this region. We're not doing anything to the posterior, to the anterior osteophyte of the facets, and just calling attention to the position of the vertebral artery when we dissect in this direction. We should maintain the planes intact in order to protect the artery. The aim is then to remove the nucleus, preserving the annulus and the end plate, and then going on to remove the lateral and medial disc projections. Remove also the osteophytes that may be present, and then we can decompress the framing here posteriorly, and avoiding to remove too much of the anterior margin of the body in order to, again, prevent kyphosis. We can see that in this movement of the tooth body, which approach each other, that even though we do some shortening of this distance comparing to the pre-op, we have very small diminishing of the craniocaudal diameter of the foramen. And once we remove the osteophytes in this region, we'll keep these foramens in the post-op X-rays preserved and large enough for the root, even though we see this narrowing of the disc space and fusion, having treated this disc herniation we see here. The second case, you can see just the same. We remove the disc. The immediate post-op, the late post-op fusion is a rule. We see that some remnants of the osteophytes will be remodeled after a while, and the framing remains open in the post-op period. Another case will show the same thing. You can see early post-op, late post-op, the remain open foramen in the post-op period, and remodeling even the ligamentar which was protruded posteriorly and anteriorly. Another case, you can see the same framing which are open, and also it's important to realize that the sagittal alignment is quite preserved in all those cases I'm showing here, and we don't see kyphosis, important kyphosis in these post-op images. Look to this case when we had again, preservation of the framing, preservation of the lordosis and the fusion. And we can also do this in multi-level lesions, as you see here, multi-level lesions, and the post-op image with preserving of the cervical alignment and reduction, of course, of the disc space. And this has been quite well demonstrated in several publications we can find in the literature. Some of them are randomized prospective studies. when the consolidated information taken from this publication is that there is a better immediate and late relief of symptoms. There is functional stability of the cervical spine in a large number of cases, temporary increase in postoperative axial pain, no definite correlation between the clinical improvement and the radiological results, which was mentioned previously in these presentations we had today. Fusion preferable in multi-level ventral compression due to osteophytes, and fusion is preferable in pre-op instability. Clinical results are comparable with techniques with fusion and arthroplasty. Early return to work, shorter hospital stay, significant risk of a degree segmental kyphosis following discectomy alone, but they do not correlate with clinical outcome. Over 80% fusion after 1 year, and radiological and clinical studies failed to show a significant difference in recurrence of foraminal narrowing. At the end, there is no superiority of any technique over the other. Dealing with the cervical alignment, we can see the angle between C2, C7 did not differ between the groups or between preoperative values and at follow-up. So irrespective of the technique, alignment of the cervical spine is unaltered. And we can go through this very special publication, which was showed in the Congress at the end of 18. We can see that irrespective to the surgical method, C2, C7 of doses was found to increase from 11 to 13, but the other parameters remain stable during follow-up. And dealing with this, we see that occipital cervical index, which is important to the horizontal gait, was demonstrated to be associated with radiological adjacent segment degeneration, suggesting that occipital cervical angle influences accelerated cervical degeneration. And since occipital cervical index did not change after surgery, degeneration of the cervical spine may be predicted by the value of the previous pre-op OCD. And here again, they come to the conclusion that single level ACD without implanting or intervertebral device may be a reasonable alternative to fusion and arthroplasty. Besides this, they put together this neck trial with a 2 years follow-up, the ProCrown trial with 8 years follow-up. And those put together 206 patients observed by similar methodology. And they come to conclusions. Key results for secondary outcome scales were comparable when the group was divided evenly in the 3 techniques, and that it's possible that adjacent level disease will occur after a period of 2 years, but this was not observed in the ProCon 8-year follow-up in the second study. So we have to look further to see if this will effectively occur, dependent of the ACD alone. And then in this study, we can see with a level of evidence of 4 that there is a significant more quality adjusted life years with ACD. and also a diminishing in the costs. The same information is taken from the second study, level evidence 2, showing that there is a need for a shorter budget for this discectomy alone. Having also had lower readmission rates, lower reoperation rates, and reduced index and total costs than those treated with fusion. So at the end, I'd just like to comment that for discectomy alone, it's convenient to do with a microsurgical technique doing together with discectomy anterior foraminotomy. There is a preservation of C2-7 cervical alignment in these surgeries, preservation of foraminal dimensions, spontaneous intervertebral fusion in large number of cases, remodeling of bilateral foramen in marginal osteophytes after fusion. Two-level discectomies are possible. There is immediate relief of symptoms, long-lasting results, and then it's cost-effective. So we can conclude that ACD alone is a valid option for myeloradicular compression in this osteophytic anterior restriction of the spinal canal and foramen. Thank you.
Thank you, Luis, for your very, very important and I would say honest presentation. While I launch the inquiry here, there is a question from a participant asking if you have any contraindication for CDA alone in your practice.
I think that extensive multi-level compression is not a case for CA alone. And perhaps if there is proved instability, also probably would be wise to go through fusion. And I think these are the two most important contraindications.
Okay, I think this relates to some of your questions here. Can you please read them for us, the questions?
Yes, postoperative foraminal stenosis in anterior cervical discectomy alone, A, may be minimized by anterior foraminotomy. B, depends on the preoperative occipital cervical index. C, follows the postoperative reduction of the foraminal craniocaudal diameter. Makes discectomy alone a poor surgical indications. It's a consequence of the adjacent disc disease. This is number one.
Number two, please.
Second, assign the correct alternative regarding anterior cervical discectomy alone. ACD promotes significant change on the C2-C7 angle. B, postoperative clinical evolution is similar to alternative surgical options. Costs and surgical times are similar to discectomy with fusion and arthroplasty. Preserves the mobility in the treated articular segment. E, sagittal balance is a serious concern in anterior cervical discectomy.
Thank you, Luis. These are the results.
I agree. I agree with the assistants.
Okay. Or the assistants agree with you. Okay. I mean, that was really a nice presentation, Luis. I think it's a challenge. Most of us, we are afraid, and you really probably need a very fine technique to get a good foraminal decompression. And most of surgeons actually they rely on indirect decompression to gain some height and decompress. But you know, I think we should look with more attention to your technique. That's for sure. I'm going to go very quickly the last lecture on this implantless surgery. It's a talk that I'm presenting. I'm trying to be very, very quick. It's on oblique corpectomy. I have no disclosures relevant for this presentation, and actually I learned this technique from my master and friend Bernard George. So when people they think about anterior cervical approaches, they are very familiar with the anterior classical approach, where you basically split medially the esophagus and trachea and all the vessels laterally. But there is another natural corridor that people disregard, which is the so-called anterolateral retrojugular approach, where you basically bounce everything medially and you split and push laterally the sternocleidomastoideo. The problem with the anterior approach is that the medial margin of the uncovertebral joint is less than 60 millimeters from the medial margin of the vertebral artery. So there is, on anterior approach, a constant fear about the vertebral artery position. Sometimes, I think it's quite the opposite. You need to have your enemy under your direct vision, like in a war. So if you look at the cervical spine exposure, looking at the anterior classical, this is your lateral limit. And the lateral limit of the anterior approach is exactly the medial limit of the retrojugular approach. And to my mind, the anterolateral approach is the only approach that can offer you a complete exposure of the foramen and of the nerve root and control of the vertebral artery. Of course, you need sound knowledge about the vertebral artery anomalies. Not always the vertebral artery enters the transverse foramen at C6 level, as it is the case here. It gets in at the C4, and look at how different are the vertebral arteries, one side and the other. You have to know that they are hypoplastic in 10%, the same size, only 1/4 of them. And you have to be aware that to know what the ability to maintain cerebral perfusion if one of the vertebral arteries is damaged when contralateral abnormality is present. This has to be in your mind before the surgery. You have also, like here, interforaminal migrations. So it's mandatory for every case to identify on pre-op MRI and CT the location and the course of the vertebral artery, and especially the entry point on the transverse foramen to avoid major vascular complications. This is an old monography that were published on the subject. The basic surgical principles, you start with a supine position, 10-degree contralateral head rotation, a cushion under the shoulder. You open between the SCM muscle and internal jugular vein. There are actually no crossing vessels or nerve except upper in the cervical spine where you have the accessory nerve. You can do a medial retraction of the sympathetic trunk, making a longitudinal incision in the longus colli sheath and retracting with a suture. Instead of dissecting this trunk, it helps you to reduce the incidence of Horner syndrome. You start the division of the longus colli and longus capitis over the top of the transverse foramen once you have confirmed the interforaminal course of the vertebral artery. You open the transverse foramen. Vertebral artery scatolonization should be started with a superiosteal dissection inside the transverse foramen. That's the key point of this operation. The vertebral artery is surrounded by a venous plexus and enclosed by a continuous periosteal sheath. And if you do a superiosteal dissection, you are always out of trouble. You have to remember the relationship between the vertebral artery and the nerves. The vertebral artery being anterior and the nerves going running down inferiorly. So this approach allows to do the oblique corpectomy. This is a regular case of cervical spondylotic myelopathy, and this is clearly the amount of bone that you have to remove, as I'm showing here, to decompress the spinal cord. So why to remove most of the vertebral body if you want to just remove the part that is compressing the spinal cord? You can do an oblique corpectomy. You go more laterally, and you can do horizontal drilling to the contralateral pedicle, and then you go and you progress, you decompress the spinal cord. So the indications, oblique corpectomy is indicated for predominantly anterior compression, which can be associated with unilateral radiculopathy. In patients with a high risk for pseudoarthrosis, preferentially arc collapse discs or pathological or adjacent levels on straight or slightly lordotic spine. And of course, you have to exclude major instability. The advantage of this technique, it allows complete foraminal and anterior spinal cord decompression with a minimal drilling of the vertebral body, less than 50% is taken out, and you preserve the ALL. Because you enter more lateral, you preserve most of this important ligament. You can do multi-levels, up to 5 levels, including C2 and C3. You avoid bone grafting and plating, and evades most of the complications related to bone site harvesting and reconstruction with cylinder plates or screws. You can do it multi-levels, like here, 2, 3, 4, and even 5 levels. The extent of drilling, it's not the same for every patient. It's dictated by the pathology. You don't need to mobilize the vertebral artery in every case, except whenever there is important extensive foraminal stenosis. As you see here, cases with no mobilization of vertebral artery to cases where you go and pursue this technique. What are the clinical and radiological outcomes and complications? Significant clinical improvement. Patients with radiculopathy tend to do better than myelopathic patients, and this was with quite a good number of patients and long follow-up. There is long-term stability, almost reaching 100%. Very low incidence of complications, axial pain 8%, kyphosis 4%, and of course some of other possible complications. The postoperative increase in the Pavlov ratio and sagittal cervical canal diameter improvement is quite impressive. There is, from a biomechanical point of view, a significant decrease in flexion and extension, a loss of 33%, which is inversely related with number of operated levels. However, none of the patients developed spinal instability. And biomechanical tests showed less instability and altered kinematics for oblique corpectomy, even multi-level, compared with corpectomy and fusion. The downside is that it can produce a slightly kyphotic effect that has no clinical worsening translation, and 30% of patients with pre-op lordosis became straight and 5% only became kyphotic. What are the barriers to the widespread use of this technique? Insufficient decompression. You need experience. Sometimes you need navigation tools. It can be really in the beginning difficult to get you oriented. And because of the specific complications like transient Horner syndrome, in 15% of cases that become permanent in less than 4%. And vertebral artery is really not an issue in this technique, this approach, if you follow a SUN technique. It's the same technique you can use for tumors like this, or chordoma, in this case with instrumentation, or a case that we have done recently of a chondrosarcoma. It seems that to us that the central-lateral approach is really in the line with the epicenter of the lesion and with the growth vector of the tumor. Plus you have control of the nerve root and the vertebral artery. After we removed the tumor, this was the vertebral artery. This vertebral artery was, at the beginning of surgery, completely collapsed by the tumor. Very nice technique also for foraminal tumors, where you never know where the vertebral artery is. It can be displaced anteriorly or medially. So mobilization and control of the vertebral artery is very important to achieve a complete resection with limit morbidity. And of course, if you do a corpectomy, oblique corpectomy, you can go and reach this cavernous angioma like in this case. So my conclusion is that the anterolateral approach is a versatile approach that is useful to master as an alternative to classic anterior approach. Nevertheless, you need an accurate knowledge of vertebral artery variations, and pre-op analysis of the scans that you have is mandatory. You need precise technical skills to make it a safer technique. You have long-term clinical, radiological, and biomechanical and biokinematic data that seems it's similar to corpectomy and fusion. It's useful for patients with risk of pseudoarthrosis. And going to the topic of this lecture, of this webinar, it can significantly reduce the cost of surgery, which is something very relevant in low and medium income countries, because you don't need to use implants and you don't need to do serial control X-ray. Thank you so much. And I remember you to come, and if COVID allows us to reach Paris in May 26 to 28 for our annual meeting at CSRS. So thank you. Let me see very quickly here my questions. So oblique corpectomy is a good indication for myelopathy if bilateral radiculopathy is present, if patients have high risk of pseudoarthrosis, existing pre-op lordosis, or instability. Fusion is unnecessary after oblique corpectomy because less than 50% of vertebral body is drilled away, ALL is removed, PLL is preserved, and bilateral uncus is removed. Okay, so just allow a couple more seconds. Okay, so actually you should never do it if you have instability, major instability. It's perfect operation for patients of high risk of pseudoarthrosis, and it can be done without fusion because less than 50% of vertebral body is drilled away. PLL should be always removed. And this was the voting. Okay. Heiko, I think we should go for the last lecture. And I mean, it's to close with golden key. I have a very distinguished friend from New York, Roger Hartel. He's professor of neurological surgery and director of spine surgery at Weill Cornell Brain and Spine Center in New York. Is actively involved in improving neurosurgical care in developing countries. Is a leader of the Weill Cornell Global Health Neurosurgery Initiative in Tanzania. I think research is a very important pillar of medical practice, and you will present us on this amazing, really amazing experience on cervical spine trauma research in Tanzania, lessons, opportunities, and challenges. Please. Roger.
Hey, thank you so much for having me. So it's great to listen to some of these lectures. They're all very, very relevant. And what we've done in Tanzania really over the last 12 years is try to collect data on various pathologies, hydrocephalus, spine trauma, head trauma, and I'll focus on some of the work that we've been doing over the last years on specifically on spinal trauma and also on cervical trauma. And thanks, Oscar, again for having me, and Heiko. It's a great idea to really shed light on spine trauma in lower and middle countries. So our work has been in Tanzania. It's a beautiful country in East Africa, but also unfortunately struggling politically, economically, as many of you know. We actually had Alex there from Namibia a few years ago as one of our conferences. So it's great to see him again as well. What we've done at Cornell is we've established a very close collaboration between our institution and the neurosurgeons and the orthopedic spine surgeons at Moi, which is one of the biggest university hospitals, or probably the biggest university hospital in Tanzania. And what we've seen over the last 12 years is, well, how do you develop a relationship between a big hospital in Europe or in North America and a program in East Africa? How do you make that work if you're only there 1 week a year? And we have been very successful with the idea of coming up with a 7-step initiative. And the 7 steps, and it's crucial really to really understand the data that I'm going to show you later, how this data was generated, is that we're going over there 1 week a year. We organize a big neurosurgical or neurotrauma symposium. And initially it was us who organized it. Now it's really our Tanzanian colleagues who do 99% of the work, and they're very successful doing that. And that in itself has been a great experience to kind of see that evolution. We have patient donations that we use to fund fellows, and we have fellows going from Europe or North America to Tanzania. And then every year we have visiting fellows from Tanzania who come to Cornell. So the fellowships go in both directions, which helps us get to know people. We identify champion surgeons, and we have constant communication. Very, very important has been clinical research, which is what I'm going to talk to you about. Every week we have Zoom or Skype conferences now where we discuss cases, research protocols, and so forth. And then finally, we come up with publications. And again, that's a great opportunity for our colleagues in Tanzania to get academically involved and really increase their publications. And here you can see a picture on top was our first global neurosurgery fellow, actually from Portugal, Maria Santos, who is a pediatric neurosurgeon there, and Oscar knows her very well. And is one of our fellows from Tanzania who came around Christmas time, wrapped up, and spent 3 months in New York. This is one of the first cases that I saw when I went to Tanzania the first time, which was 2008, was a fracture dislocation, the odontoid process in front of C1. And we were able to treat that successfully with an OC fusion because in 2008, we brought over some instrumentation. So that was one of the first cases that I got involved with. And that was a very significant cervical injury. And this really has been going on. Every year we go, we see a lot of cervical trauma. We decided to study cervical or like spinal trauma about 5 years ago now, because we saw that there was significant number of patients that would come in, and we just didn't know how were these patients being treated and what were their immediate outcomes. So we decided to implement the database. And again, this was really then done by our Tanzanian colleagues in collaboration with our fellows. And we got our Cornell statistics department involved and so forth. So it's been a very, very close collaboration ever since. We use standardized collection tools, and this resulted then in our first publication on spinal trauma in East Africa. This was run by Andreas Leidinger, who's a neurosurgical fellow and who's now practicing in Barcelona in Spain. And he wrote up together with our Tanzanian colleagues, again, our experience or their experience with spinal trauma. And the key findings here were that it took a long time to get these patients to the operating room if they came in. And the lack of instrumentation was a big problem, as you can imagine. Insurance status, so basically payments were a problem because patients couldn't pay for surgery. So only the ones who got surgery were the ones who had good insurance. But we also saw, and that was really fascinating, that surgery and earlier time to surgery was associated with better outcomes. Tanzania is a big country. You can see that the delays from trauma site to getting to the hospital were very significant. So there are about 2.7 days to get to the hospital for patients less than 100 kilometers away, 5.4 for patients more than 100 kilometers away from Dar es Salaam. Dar es Salaam is here on the coast, is probably the biggest city in Tanzania. And then the delays in the hospital, of course, and we'll talk about that. So we studied in this publication 180 patients. Mortality was higher in those patients who didn't have surgery, and hospital stay was between 20 and 43 days. As you can see here, patients who had surgery tend to do better than those who didn't have surgery. 40% of all all patients underwent surgery. The average time to surgery was, however, 33 days. And no patient had surgery within 24 hours. So these were very, very exciting numbers to look at. And this is not really sophisticated research. This is basically just a data registry that we started with our fellows, collecting the numbers of what's really going on in the hospital. As you can see here, patients with incomplete injuries had a lower chance of undergoing surgery. And again, the delays, time to surgery, were significant, 30 and 36 days. This is Maria Santos operating with one of the visiting doctors from the UK. What were the factors affecting surgery and outcome? Well, the significant factors for undergoing surgery was the AO spine classification. So significant fractures, B and C type injuries were more likely to have surgery, which is obviously understandable. Time to surgery was significantly affected by insurance status. So patients who didn't have insurance went to the operating room not at all or later. And then finally, the patients who improved neurologically were the patients who had shorter time to surgery and patients who actually had surgery. So this was really nice to see that surgery actually had a beneficial impact in these patients. In terms of costs, this is just to show you that patients with private insurance were billed more, but the hospital was also paid. These are just some of the numbers. A pedicle screw is $70 on average, a CT scan $70 to $90, ICU bed $13 per day, and so forth. So we published that paper, and then we did a follow-up study. One of our fellows who was there then last year, Scott Zuckerman, he's now a spine fellow here at Ox Spine in New York with us, with Larry Lenke. He did a really, really interesting study together with the Tanzanians where they only looked at the patients who had surgery. So 97 patients undergoing surgery. These were the types of procedures done. And because of the shortage of instrumentation, they noted that a lot of patients underwent short segment fixation, and they were just designed, the surgeries were designed in such a way that there were concerns about the length of instrumentation and so forth, because there was a shortage of instrumentation. These were the cervical surgeries that were done, mainly ACDFs, posterior laminectomies and fusions, and a number of cervical corpectomies. Now, the most important thing that came out of this paper was that each day taken earlier to surgery offered a 4% increased odds of neurological improvement. And this really hasn't been shown really in the Western literature to that extent, that this really tight relationship between surgery and improved outcome. Now, another publication, we looked at non-operative treatment. So what happened to those patients who came in with spinal trauma and had no surgery? In that particular patient cohort, 145 patients were managed non-operatively. However, 86% of those patients actually met criteria for surgery. Patients who were treated non-operatively had a 7-time increased odds of death. And the only factor that emerged as a predictor for non-operative management was cervical injury. And we think that was, again, because of a lot of these patients were more unstable hemodynamically and probably never made it to the OR, and a lack of instrumentation. So based on these data, we came up with some recommendations that instrumentation should be provided at a more cost-effective level. And of course, training in cervical spinal surgery, ICU care needed to be improved, and the implementation of spine trauma protocols. And that's why I want to go now towards the end of my presentation. Another paper we published was cost effectiveness. We were able to show that spine surgery is actually cost effective, and spine trauma surgery was more cost effective, meaning lower costs per disability adjusted year compared to other surgical intervention in LMICs. So surgery for traumatic spinal injury neurologically improved, more cost effective than a lot of the other treatments like hydrocephalus, general trauma care, fracture dislocation fixation, and so forth. We also looked specifically at only cervical trauma, and this was retrospective, 101 patients treated with cervical trauma, 25% treated operatively, mean admission day 16, and the odds of mortality increased with a complete spinal cord injury and also with a shorter time injury to admission. And that was very interesting to see, because we kind of assumed that the sooner you get patients to the hospital, the better they do from a neurological perspective. But here we got the first idea that this may actually not be the case. And we thought that maybe there's some kind of self-selecting population that presents itself later after trauma to the hospital, that the ones who were sicker and had a higher chance of dying, they died already. And then the ones who come to the hospital later are the ones who are probably going to survive and have a better outcome. Therefore, if you get in the patients early on, you may actually see a higher mortality. And that's what we saw here in cervical patients. So we then started thinking about the implementation of a spine trauma protocol. And that was really then, again, one of our fellows, Scott Zuckerman, who spent 6 months in Tanzania, who really spearheaded that. And the idea was to get in patients preferentially who have non-complete injuries and try to get them in as soon as possible, hopefully 3 days after trauma. We got some support from DePuy Synthes that they offered some instrumentation. Some other companies gave instrumentation as well. So we were able to negotiate with the hospital for this particular protocol that the hospital would not charge the families and the patients for the instrumentation, because we brought in instrumentation for a while, essentially for free. I know that that is not sustainable, but we tried to do that for the purpose of implementing this protocol. So we're all very excited. We thought, well, now we're going to really revolutionize the spinal trauma treatment in Tanzania, because everybody's going to have surgery right away. And this is what we saw, and specifically with cervical trauma. And this is an ongoing study. So we're just looking at the data right now. And here I'm showing you some data comparing now the initial cohort, which is, those are the patients before implementation of the spinal trauma protocol, the first number of publications that we came out with, and then the current patients who were treated after implementation of the spine trauma protocol, with Scott Zuckerman being there, and with everybody trying to get those patients into the hospital and into the operating room as soon as possible. So initially there are 105 spine trauma patients. Now after the protocol, 50, and 33% of those patients underwent surgery before protocol. 72% of patients now underwent surgery after the protocol. Time to surgery decreased from 20 days to 5 days, but mortality increased, or survival actually decreased. Of the cervical trauma patients who were treated before the protocol, 73 survived, and only 36 survived of those patients who came in after implementation of the protocol, which is, quite shocking. Now let's look at those who had only those patients, cervical trauma cases, that actually had surgery before protocol and after protocol. And here you can see again the mean time to surgery was 20 days before, 5 days after, and the survival before was 82% and now 47%. So by actually decreasing the time to surgery, we actually increased the mortality. And this is obviously a surprising finding, and we're currently in the process of analyzing these data more. We didn't see this for the rest. We didn't see this. We did not see an increased mortality for thoracolumbar trauma. This is specifically for cervical trauma. You can see here that before and after, gray and red, the number of Asia A patients was actually worse before the protocol, and now a little bit less, but we have now more Asia B patients. So you can't really explain these numbers by those patients being sicker or more severely injured. And again, we're going through a detailed analysis as we speak. The other thing that happened since concurrently to the implementation to the protocol was actually the implementation of a new ICU at Moy. And so there was a little bit of an overlap. A new ICU was established. There's a concern that the nurses and the doctors may not have been properly trained. So we're looking into that as a possibility also, why maybe some of these patients received less ideal pre and post-operative care. So as a discussion point or summary, so More patients now, after the protocol, were offered and underwent surgery. We cut down the time from time to trauma to the surgery. However, we saw in cervical patients an increased mortality. And the concern was, and if you look individually at those patients, that these patients were taken to the operating room maybe in a less resuscitated way. They were hemodynamically unstable, and a lot of these patients had complications in the ICU that then led to their demise, unfortunately. So patient selection for surgery is very, very important. So just by optimizing the time to surgery, you cannot expect that necessarily the mortality is going to go down. So summarizing, if you look overall at spine trauma in Tanzania, there's a prolonged time to the theater due to lack of instrumentation and lack of insurance. However, in general, patients who have surgery and earlier surgery tend to have a better neurological outcome. After our aggressive implementation of a trauma protocol, in cervical cases, we decreased the time from trauma to surgery, but we also saw an increased mortality. And we think that it has to do with the fact that you should not just focus on, as a surgeon, getting those patients to the operating room, but you really have to think about the big picture, the infrastructure, the ICU care, perioperative nursing care, intensivists, and so forth. But we're still analyzing these data. So thank you for your attention. And I want to thank our collaborators and everybody else who was involved in this project, especially our colleagues in Tanzania, of course. All right, thank you.
Roger, great. Nice lecture. Thank you very much for sharing your experience there. And I just, from the first question, Oscar, because it was in my mind, and I appreciate how the academic way you're approaching this difficult topic and to look into data. And I think it's the only way to build an environment which will last over more than 10, 20 years. And I want to have your idea of, you said you had a grant, there were some implants. So what is your experience also with local politics and industries, and to put them on the table to build something which will last for the next years? So because if we bring these implants and instruments, the expensive ones, to the world, it will not be possible, I think, in most edges of the world in the next 10 years that they can sustain these costly implants.
Yeah, I think that bringing in instrumentation for free is not the answer. We did it in this particular, for a particular purpose, to kind of implement the protocol. Sure. But I mean, you have to convince the government and the healthcare system locally that it is in their benefit to invest in these types of implants, and then they'll do it. For example, I've been working on head trauma and spinal trauma for so many years, and the hospital never really seemed to be so interested in it. And then last year, in 2019, we had a few deformity surgeons with us. And they treated some of the spinal deformity cases at Moy that were scheduled to go to India for elective scoliosis surgery. And suddenly the hospital realized that, wow, now we can treat the patients here. We don't have to spend thousands of dollars to send them to India for surgery. And I got letters from the hospital thanking me. I was not the surgeon, but thanking me for organizing this whole initiative. And I'd never gotten a letter about spine trauma, head trauma, because those patients are not being sent away for surgery. They die locally and they never make it to India, right? So I suddenly realized, you really have to show the hospital the financial impact and the benefit of providing care to these patients. And if you can do that, the healthcare system will listen, unfortunately. That's the only way to do it. But that's exactly the reason why we're collecting this data now and we're publishing it. And that's why we did the cost effectiveness study. So you have to work with the healthcare system, but you got to speak their language. You got to understand what they're listening to, and what they listen to is the financial aspect.
Excellent point. Thank you very much.
Very good, Roger. It's really impressive, your first class, the job you do. And as you said, most important is the conclusions you can derive even for our practice in the Western countries. You see most of data there that can apply to us and can answer some of the questions. So very quickly to go on your inquiry, I changed a little bit the phrasing in order to have just one correct. Roger. So can you please read the?
Sure. Cervical spine trauma outcome data from LMICs show that A, shortening time from trauma to surgery can be associated with worse outcomes. B, the majority of patients with unstable injuries undergo surgical treatment. C, surgery in isolation without IC and adequate perioperative care has huge beneficial impact on outcomes. Patients with complete injuries are more likely to undergo surgery. So should I give the answers or no?
Yeah, just.
Yeah, well, I mean, we based on our, I mean, there are actually two right answers. I apologize. A is also correct, but I think the system doesn't allow you to pick two, obviously.
Yeah, I changed the phrasing a little bit. Yeah.
Yeah, but I think it's good that everybody realized C, because I think that's the most important thing, that surgery in isolation is not the answer, and that's certainly the lesson that we learned. That if you provide surgery, you got to make sure that you have anesthesia, ICU care, nursing care, everything has to be synchronized. You know, just getting somebody to the operating room earlier doesn't mean that they're going to have a better outcome.
Very good. Philippe, I love to hear from you.
Yeah, just a comment. I'm Philippe Marcel, and I would like to thank you guys. And I'm a very old surgeon, and what I learned from you guys, it's what I learned from my bosses. I think with time, what we observe, we have a big pressure coming from the big companies, and now they increase the necessity to use a lot of tools. I mean, monitoring during surgery, C-arm, robo, fusion, fixation, etc., only for, a commercial reason. And what these guys demonstrated today is what I learned from my boss, with a minimum of tool, with skillness and a very good practice and a good indication, you can demonstrate, as Jamel has done, that you have very good results. So guys, I agree with you. Even in France we have some kind of problem, health problem, due to increasing curve of expenses. So now the government just stop us. So I absolutely agree with you guys. With minimum tools, we can't do a very good surgery with very good results. This is my point of view. And thank you. It was really great.
Great.
Michael.
Thank you very much. It was a great meeting, Oscar. I can join the opinion of Philippe. Really was a nice meeting, and we have to do this again. So hope to see many of you on our CSRS annual meeting in Paris. And if there are any questions, feel free to reach out to any of us of the CSRS board and of the society. We are open always for this kind of projects and ideas. Thank you very much.
Ahmed, please unmute yourself.
Thank you very much for all the lectures. You know, I fully agree with what Philip said. And actually, you know, one like me has been in neurosurgery for over 40 years. And we used to do the laminectomy. We used not to use an instrument. And now we have the media. I think the problem is not, and this is a very ethical problem, because it's not only the companies. The companies, we understand, their motivation is to sell and to get money, but the role of the media. When the media, for example, for especially people in private hospitals, they say, oh, this is using the best technique, and so the patient get misinformed and just run with it. This is a very ethical and very important question. Now we have to actually to educate again our young people. That is how many courses, if you can see, about different implants, workshop for certain implants or certain navigations or so. But I cannot see in the last 3 or 4 years any single workshop about the basic technique, for example, without using an instrument. This is part of our responsibility as teachers? So this is one of art. That is, we have to be aware about this. And as we saw from the global studies, they are almost more than 2/3 or 90% of the people, they cannot afford it. So this is, we have educational obligations, we have ethical obligation to really stand on basic science, not on the propaganda of the companies and the media. I don't know how to do it, but really we have to, all of us, really to deal. Companies, yes, they have motivation, but the problem is the media. How to control the media?
Yeah, I fully agree with you. And that's why, as Roger said, we can learn so much from LMIC countries. You know, we could probably, in our world, part of the world, simplify a lot of our surgeries with less cost, and at least cover more people and operate more people with the same money, as Ronald from Brazil was saying before. Anybody wants to make a comment before we close?
Yes.
I think we are running now almost 3 hours of webinar. It seems that it was really interesting. So to conclude, I would like to thank Anna Luisa for hosting. She did a great job during good technical conditions for the webinar. I'm very grateful to the faculty. They delivered very insightful lectures. And actually, I invite them to write up some proceedings of this webinar and to make them available for a greater audience. It would be nice to write some of the stuff that we developed here today. And finally, a big thank to all the participants. I hope you enjoyed the webinar, and it was really a humble contribution to improve patients' outcomes worldwide. We'll be back next year with more webinars. Stay tuned. Merry Christmas and Happy New Year to all. Thank you so much.
For you too. Bye.
Bye-bye.
Thank you.
Thank you. Thank you.
It was great pleasure.
Bye-bye.